So basically, again, we run into, when we do follow-up care, that question of how do you ask questions about sleepiness and those kinds of things. It again is still about that story, and we start with, how do you feel? Because objective data is really important, but subjective is the stuff that drives people's behavior. Even if we can demonstrate that somebody improves their apnea-hypopnea index, if they are unwilling to put that mask on, if motivation doesn't drive them to do it, they won't. And that's like anything. That's why hypertension is so difficult, because people don't check their blood pressures, they don't take their medications because they think they feel fine, and then they have a stroke. So when we look at these kinds of things, both of these things help, the subjective versus the objective data. So subjective things, you start with, are you sleepy? Are you tired? Are you feeling better? Are you feeling more alert? Those kinds of things really help us to start to get a handle on things. Objective data we can get in a couple of different ways. Primarily from the PAP devices. They now have technology that allows us to be able to do those kinds of things. Having kind of an integrated understanding and approach to how to do this really helps. So the objective things that we're looking at, are you still snoring? Sometimes you got to ask the wife. Has your blood pressure improved? That's something we can measure. Have them go and check it. Is that diastolic pressure come down? Have you lost any weight? Although this is tricky. Sometimes people with sleep apnea that get it treated feel so good that they gain weight because they celebrate with food and beverages. I feel awesome. So let's have cake. And then they gain weight. Another reason why those auto-titrating devices are useful, because you gain a little weight, maybe your sleep apnea gets a little worse, maybe the machine goes up a little bit. Is your reflux better? Is your heartburn better? Are you having less tooth erosion? And well, how's your functional alertness? This is, am I falling asleep in meetings? Is my boss still mad at me because I'm not paying attention? Am I making too many mistakes at work? Those kinds of things are a bit more objective than that how do you feel kind of stuff. The subjective measures, the daytime functioning, just how am I moving through my day? Our patient 0 talks about how he could not stay awake for more than a minute watching a movie, and now he can go to a movie by himself and see the whole thing. Focus and memory are improved. Irritability is decreased. More dreams. And that's usually a good way to know that you're on the right track. And then decreased headaches, improved chronic pain issues, which also can lead to less dependence on narcotics or other pain relievers. My story about the sleep apnea, beyond my confusional arousal, is getting better. 3 weeks after surgery, even though it hurt, I know you asked me, it did hurt. And the yawning about 2 or 3 weeks after surgery, because you try not to yawn because it stretches all those tissues out, but trying not to yawn hurts worse. But about 3 weeks after my surgery, somebody cut me off in traffic. And my response in the past had been to be very irate, a little irritable. And when this guy did it, I went, dude, I wish you'd have made a different choice. And I went, who am I? That is not what I typically would have done. That was kind of awesome. And then my son was still in high school and he didn't do his homework. And I'm like, well, dude, you're going to have to go do it instead of. And I'm like, I am so much more patient. I'm so much more pleasant to be around. And I was very mild. So I was one of those people who was significantly impacted by mild disease. And I did notice right away, even like days after surgery, that my dreams were different. I was dreaming more, and I was dreaming much more vividly. I've always kind of dreamt in color, but I would dream in smell-o-vision. I could smell things in my dreams, incredibly vivid, and just go, wow. But when we have that initial improvement in dreams, a lot of times patients will wake up and still be groggy because they have REM rebound, they have extra, so they're paralyzed more of the night, and they wake up and they're like, I'm so tired. It's kind of like the body's going, that was awesome, I'd like some more. So if you could just manage to get like 16 hours of that, we'd be better. So it usually takes 3 or 4 weeks to finally normalize all that sleep architecture so the stages are happening where they're supposed to happen. People who say, well, I feel so much better, I don't need as much sleep, are actually shortchanging the body's ability to get through that whole process and normalize everything. but typically 3 or 4 weeks for most people. So your your follow-up measures for PAP devices, there's 3 primary things that we're going to talk about. The first one is downloading the data. So most of the machines have a card in them that you can take into your durable medical equipment company, put it in a card reader, it downloads the data. You can see how many hours did you use it, how was your mask leak. On the auto devices, what was the average pressure that was used and what was the average apnea-hypopnea index. You can do it over a range of days. We have new devices that we're dispensing that are called AutoSense 10s that we can remotely connect using the cellular network, so they don't have to connect to Wi-Fi, and we can download that data. It downloads at noon every day, so we can see where they are. I have a patient who's struggling with therapy, and before I could get to that data, I could see that his device was working okay, but he was only using it for like an hour. Now that I can access the full menu, I can see that he's trying. He's wearing it for 2 minutes and pulling it off. He's wearing it for 10 minutes. He's sleeping for maybe half an hour, and he's pulling it off. So this is somebody that perhaps some mask desensitization can really help him work through some of that stuff, and we can troubleshoot whether it's the mask isn't comfortable, can we get you on the right mask, can we get you on the right track? Because he's motivated to feel better, he just can't figure out how to use the device in a way that he can tolerate. He is unfortunately not like our patient 0, who's like, give me that mask, I'm good. On the auto units, we can adjust the range. It is a prescription that the doctor writes, so for example, 5 to 15 centimeters. But if we look at that and we see that the person is actually ending up at that higher range, we can adjust that pressure setting so they don't have to go through the time it takes for the machine to adjust. Because it has to wait and sense before it goes up. It won't just go from 5 to, oh, this guy needs 12. It has a specific way, and so the patient will continue to obstruct until they get to that optimal pressure. So sometimes we can take that and make it, say, from 10 to 15, and they'll have more time at adequate pressure if they can tolerate it okay. Sometimes we take it down a little bit because that excessive pressure seems to be waking them up. So we can do that by looking at that compliance data. And then are side effects manageable? We earlier talked a little bit about the short-term effects of nasal CPAP. Sometimes you have patients who wake up with a dry mouth on CPAP because their mouth is coming open. Sometimes you can use a chin strap. Sometimes you switch to a full face mask. Even with a full face mask, patients are going to have a dry mouth because their mouth is open and the air is going over that tongue, so it's a little like asphalt in the morning. But it's something that we usually adjust to, just like if you ever lived at sea level when you moved to Denver, you know, that first month of trying to walk up a little tiny hill, you know, it's like, that's a lot. Our bodies adjust and make those changes. We use heated humidifiers in the PAP units to help cut down on the congestion resistance, but it still takes some time for some patients. Some patients end up with extra runny noses instead. Most patients get congested and dry, but there are lots of therapies that we can do to do that. Not petroleum up the nose, but other things like the nasogel, that's the saline-based water-soluble gels that can help improve the comfort. When we look at the oral appliance therapy, again, we're going to be looking at a few different measures to make sure that somebody is compliant. We don't currently have technology that says, yes, it was in a 98.5 degree mouth that had the adequate humidity. We don't have those, but they're working on chips that they can put in those devices so we can actually see if patients are wearing them the way they're supposed to. Doesn't currently occur, which is problematic for patients, who, for example, who are over-the-road truckers. With a diagnosis, and the DOT requires that they have compliance data that says that they're using their therapy and it's effective. So, so for those folks, they need to have some way to do it. Right now, it's self-report on those. So the first thing that we look at when we look at the oral appliances is it's not the same as PAP, where with PAP, we either set a range and figure, you know, on the APAP units, or we set a constant pressure on the CPAP. With an oral appliance, we got to figure out how much we need to move that jaw. And so it takes a little bit of time, and we don't want to just yank it forward because you're going to end up with somebody with a lot of soreness and sometimes TMJ issues. The way the device works is either it's a mandibular repositioning device where they move it, or sometimes they just hold it in place so it doesn't drop back and close off that airway. And so they'll start by putting bands or small pieces on there that pull it forward in small increments of millimeters. So I'll pass this around. This has this small piece right here, and so we'll expand how long that is to see how far we need to pull that jaw forward to make sure that we don't have it. And so we usually say, are you still snoring? How far are we pulling it forward? And that's what we call titrating the device. It happens over a series of weeks. Start with, are you snoring? Are you sore? Make sure we don't cause too much inflammation in that jaw area. So that's the first piece that we do. And then how many hours a night and how many days per week are you using it? Self-report. And then we do a follow-up study about 30 days after we think they're fully titrated with a home sleep test to see where they are. This is how we do it, to make sure that they're still getting good sleep and we're not missing some events. The side effects, we can have people with TMJ issues. Somebody who's got pre-existing TMJ is not a great candidate for oral appliance therapy, just because it's going to be hard to manage that if they're already inflamed in that area. We can also see bite changes. There are morning aligners, which is kind of like a retainer, or they're just little pieces that you can put in your teeth to reposition those muscles and relax them. When my husband was on oral appliance therapy, he just put this little piece in his mouth when he's in the shower. Otherwise, when he would bite into the bagel, his teeth would hit and it was really uncomfortable. The bite changes can be problematic for some people. This device doesn't have any articulation in the front to prevent the front teeth from moving. Most patients are okay if the side teeth move a little bit, but some patients absolutely don't. I had a gentleman who we were talking about therapy for his apnea, and he said, I have perfect alignment, and I never had braces, and I do not, can you tell me my teeth won't move? I said, I can't tell you that your teeth won't move. And he said, well, then let's look at the PAP as a first line option for me. And he also had TMJ issues. We need to be able to give patients that choice to see whether that's what they want. Any questions?
Do you ever use the oral device with the CPAP?
Yeah, it can be difficult because some of them are bulkier and it's hard to get the mouth closed. And especially if you're just using the nasal pillows like Shaq showed, or just the nasal mask, if your mouth is open, the air leaks out your mouth because this is a, open container. So if you can't keep the lips closed, it's a problem. This one is great because it's so small, it's not bulky, and so it's easier to keep the mouth closed. And we can do combo therapy for patients who want to do that, especially people who are ending up at the top end of that PAP range. It can be hard to tolerate because you can dry out so much. And so using one of these, you can decrease the amount of pressure that you need, and you don't have to titrate maybe as much. So it kind of depends on what you got going. Obviously, with those kinds of devices, people have to have teeth. They don't have to have all their teeth, but they do have to have a certain minimum number of teeth, and they can't have significant periodontal disease or it's just not going to work. We don't want people losing their teeth that we're trying to treat them for their sleep apnea. But even with PAP, you kind of need to have at least upper dentures in, because otherwise it's hard to get a seal for the mask. The nasal pillows are probably the best option for those kinds of people, but if you don't have teeth, it's hard to get a good mouth seal if you're just using that nasal interface. So trying to find ways to make that work is really important to get people what they need. And all of it still beats the old alternative, which shortly after I started in sleep, they had, we found PAP. Before that, it was a trach. So, and a trach is pretty much 100% effective for everybody, but most people don't want a trach. So, all right, awesome. Thanks so much. I think they're going to bring in our lunch.